Testing 1 1. Testing.
Yeah, that was a trial. Again, thank you very much, everyone, for being here today. I'm going to apologize just once. I apologize for summer cold, so if you hear me hacking up here, it sounds like I got some deep voice. It's not that I'm upset with anyone. I just have bad congestion. So thank you all very much for being here. Again, there's a lot on the agenda today, and so in that spirit, and speaking of spirits, we will call this board together to order at 1:10, and the first order would be to ask Ms. Leanne Franklin, who's Director of our Spiritual Services, to come up and give us our opening prayer, and then if you would please join me in the pledge after that. Leanne?
It's always a privilege to be here. I come just an hour ago. I was sitting in a room with Dr. Kramer, our Chief Medical Officer, as he delivered news to a family about their 30-year-old who had died unexpectedly, and they wanted answers. He said this young woman should not have died. It's a difficult conversation. And I had the privilege of witnessing Dr. Kramer's heart and his mind and his words as he took all these different opinions, all these different emotions, and they saw his heart, they saw his compassion and his wisdom and his knowledge and experience. And we ended with a sense of great sadness, but a sense of peace. And it's with that spirit that I will begin our prayer this morning, or this afternoon. We gather this afternoon aware that life is not easy, and that there are often many different opinions, many different attitudes, and yet we come together. We come together with our hearts united in compassion. We come together with our minds informed by a wisdom that is greater than us all. And we ask in this moment that we do have open minds and that we have open hearts, and that we can come together from our different places of view, different points of view, and that we can have unity of spirit, and that we can come together with a combined sense of compassion and with a focus on the mission that gives us all purpose and meaning and a call to our lives. Let us be of one mind, one heart, and one spirit. With that, we say amen.
Amen. Thank you, Leanne. Scott, no one said, okay. I thank y'all very much, Leanne. Thank you very much. I've just been advised there are no one has signed in wishing to address the board, so we'll move on to item number 4 on the agenda, which is the approval of the June 14th minutes. As all of you know, you've had those on the portal for your review. If there's any discussion, I'd entertain it at this time. If not, I'd entertain a motion for the approval. I have a motion by Reverend Emerson. Second by Dr. Weber. All those in favor say aye.
Aye.
Thank y'all very much. Passes. One question. Oh, yes, DT, I'm sorry. Your name's misspelled, okay? Yeah, that will be adjusted. Thank you. Be handled. Thank you very much. Still early in the meeting. Don't go there.
When you misspell DT.
Yeah, DT's kind of, I was going to say, yeah, we're talking about the DT part, aren't we? I know Ralph's thinking something. I'm going to leave it alone. Due to the extensive agenda today, I'm going to move forward. Board action, only thing I would say is due to the length of the agenda today, I'm not going to, I usually advise this board. I have the pleasure and privilege of sitting in this chair. It's three of you on this board have done in the past, so you get to go out and see a lot of our employees do things. I actually had the privilege of attending Friday evening, a huge crowd of JPS employees and their families over at TCU at the annual get-together for the talent show. They had a world-class person there to do the judging. Dorothy, thank you for, nobody wants to do that job. You do a great job of doing it. Dorothy was one of the judges. But again, it's just great to see the employees. We know we have a lot of talent. I'm not using this as a pun. There's a lot of talented people within the halls and the walls of this institution, this district. It's kind of fun to see them on a night, show their other talent. And we have some really talented people that are very musically and inclined and things like that. So anyway, Robert, I know HR and communications and the different departments were involved, but it's just great to see the employees and enthusiasm and all that that was there. So I thank you for that, but I'm really not going to go into much else. We got a long to do. I'm going to turn it to you for any comments you may have.
Sure. Thank you, Mr. Chairman. A couple things I wanted to bring to y'all's attention. First thing I wanted to call to y'all's attention is when Mr. Montgomery was chair and when Mr. Petty was chair and Pastor Emerson was chair, each one of those at various times receive awards from the community. And it's always a nice situation when that happened because our board chairs, those that have come before us, and I feel certain those that will be in front of us, have always gotten recognized from the community, and it's greatly appreciative. And I appreciated, Pastor, what you did, and Trent, what you did, and Steve, what you did. And each one of you all had different circumstances, but the one thing that comes up at JPS is never is there a time in your tenure where it's boring. It's always something going on, and it's always challenging with high rewards. And because of that, our board chair is going to be recognized. Our current board chair, Charlie Powell, is going to be recognized by the Dallas-Fort Worth Hospital Council. And he's going to be receiving the Distinguished Healthcare Service Award this year.
Yeah, thank you.
And that is
Robert, thank you for that. Like I indicated, though, it is a lengthy agenda. We probably do need to move along.
I understand.
So thank you, but thank you for the comments.
My mic is on, so
thank you.
It's an honor to work with this board and the chairs that we've had, and as I said, the chairs to come, because we've got good people, and it's nice to be recognized by the Dallas-Fort Worth Hospital Council. And thanks to the Dallas-Fort Worth Hospital Council, because they have paid a significant more attention to JPS. And Bill Whitman was on their board, and Bill Whitman served JPS well in that capacity on that board, and I appreciate it. And I appreciate Steve Love for what he does as their executive director, because I think JPS didn't always have such a strong voice and a place at that table. So accolades to the Dallas-Fort Worth Hospital Council. One, Charlie, to reach out and see your leadership, but the leadership of this board. Amen. And where this board has come. So I'm very thankful for that.
Mr. Chair.
Yes.
I know maybe I'm behind time, but didn't our CEO just receive an award?
I'd say so.
Yes.
Yeah, but that's not part of our time here. We have limited time.
You go right ahead, Robert. Now that, why don't you talk about that one,
No,
Robert? We've talked enough about the other one.
Yeah,
so.
we're not going to talk about. We don't need to talk about that one. But I am proud of this board, and I'm proud of where we're heading and where we're going. Mr. Norad sent a email out to me wanting to know a little bit more about telemedicine and where we're heading on telemedicine and where we are and what our future in telemedicine is. You know, there were 4 pieces of legislation passed this last session. There was SB 1107, which was the large encompassing bill. There was Senate Bill 922, which dealt with some of the procedures and regulatory aspects of telemedicine. There was Senate Bill 1633 and House Bill 1697. Those were the largest amount of bills ever passed on telemedicine. It was the work of the Texas Medical Association and the divisions of medicine in Texas that got together and looked at the future of telemedicine. Telemedicine is going to be something that is going to be key to JPS's future, and what we do with telemedicine and how we handle telemedicine correctly. This is not unlike 15 years ago when people began to discuss what are we going to do with robotics and how do you deal with it. It's a river stream, and trying to control it in the proper way and trying to deal with it in the proper way, I think, are the most important things. But I think with Dr. Schrader and the medical staff and the leadership that we have, we will venture down telemedicine in the most positive of ways and trying to figure out how that happens. The other thing that you'll hear from me now and in the future, and you'll hear it from this staff, is we have to look, particularly in light of any potential changes that would come before JPS, we need to look at our addressing of wellness, not just our addressing of sickness, and where we go with the future of hospitals. And when hospitals become a situation where it's not necessarily the place to go. It's the place that we have done services in the home or services in other settings or services in clinics, or the answer would be telemedicine. So I think over time you'll hear a lot more from the staff as well as other hospitals and other entities throughout the nation about where we head in the area of telemedicine. So I'll be happy to sit down and talk with anybody. We have started, or we will be bringing to the Finance Committee, a pilot program of telemedicine that we'll be doing with employee health. We think that's a nice place to start with our employees and start looking at a telemedicine program for them. And we're going to initiate that and move forward. And then we'll be looking in the future at continuous programs for telemedicine, and if that's the answer for our patients and where we go. I'll be probably next month. Yeah, it's in the process right now, Dr. Weber. And so that will be coming up in not probably the next, because the next Finance Committee is fairly quickly. It's in 2 weeks. So we'll be bringing that forward and giving y'all not only an update on the first program, but really the overall strategic approach to telemedicine at JPS and what we do with it and how we handle it properly. And it's that thin balance between technology and human touch. And if you can keep that level of technology available so that you reduce the number of people that are coming into a hospital, and yet you still have the caring touch and the caring sense that we have provided so strong at JPS, I think we'll be in good shape. So we will continue to work at that. The other thing I wanted to mention to y'all is we have over 2,000 nurses at JPS, 2,000 and some of the most qualified, best people you ever meet. And for those of you who get your care here at JPS, for those of you who have been a patient at JPS, you get to see our nurses up front, and they are as good as they get. And I've expounded numerous times on my stay here as a trauma patient and what it was like to have the touching hand of a nurse take care of you. And I stand behind our nurses so significantly because they're easy to stand behind, because they're some of the best people you can imagine. In order to have a good team of nurses, you have to have a good leader. Dorothy knew that when she was CNO here, and Wanda Peoples is that good leader that we have as our CNO. And I don't want to steal any of Wanda's thunder. What I'd like to do is have Wanda come up and tell you about an announcement that came because of the two women that you're going to have up here with Elizabeth and with Wanda. So Wanda, if you would, spend a little bit of time and y'all tell us what you all have done, because it's pretty impactful. And Trudy, please come on up.
Good afternoon.
Hit that mic. If you'll, I think it will turn colors. It'll turn some color.
Okay. What I would like to share with you this afternoon is one of the highlights of my 42-year career. And I am so proud to announce that JPS has received the designation of being a Pathways to Excellence organization. All right. This is a designation through the American Nurse Credentialing Center. And you may have heard of magnet organizations. Well, Pathways is Magnet's sister. They kind of go hand in hand. And when we were looking at our journey and where we wanted to go, Magnet is geared more toward research and those type things. Pathways is more designated toward the nurse and nursing practice. So we chose to go down that path. So Pathway organizations recognize healthcare facilities that create a positive work environment for nurses. They are considered one of the best places nurses can work. They improve nurse satisfaction, patient satisfaction, and patient safety and quality. So it's based on 6 standards, and under each of those standards are multiple things that you have to meet in order to become that. Shared decision-making, leadership, safety, quality, well-being, and professional development. So nurses, organizations that have Pathways have better nurse engagement, they have better nurse retention, better interprofessional collaboration, like I said, patient safety, and higher quality outcomes. So we've been working on this for about a year and a half, And it's been, we've been working on it for many years, but we did the actual submission and all about a year and a half ago. I brought Trudy and Elizabeth up here with me because they did a lot of the lion's share of the work. Elizabeth did just a yeoman's job. Most organizations have a dedicated person who that is their full-time job, is helping to coordinate all these functions. We had to submit a binder that was right at 2,000 pages that showed evidence of how we met all these standards, and they all had to be in the same voice, the same typeset, and Elizabeth did all that in addition to her everyday job. She is our manager for our specialty programs, and I just cannot thank her enough for the work that she did with this program. What happened is, like Robert said, we have over 2,000 nurses, 2,164 nurses. We had to submit all this evidence. It had to go then to 3 different surveyors that would review all this to see if we were meeting the standards. And then after that, they sent a survey out to every one of our nurses to see if we were truly walking the talk and meeting what we said we were doing. Once they send it in, 60% of our nurses had to respond in order for us to be eligible. And of the 60% that responded, 75% had to answer agree or strongly agree. And we had to meet 21 of 26 criteria. I'm happy to announce JPS had 26 of 26 criteria.
Oh, that's great.
So, like I said, I could not be more proud of the nursing staff here and what we have accomplished and what this team has done. And I'm truly humbled and proud to be their leader. So thank you very much.
Wanda, thank you very much. And Elizabeth, yes. Go ahead, Chuck.
I've never said this to Wanda, but I'm speaking from experience and my heart. All you nurses made me a better doctor.
No question.
Thank you.
That's great. And again, Wanda, 42 years. We expect to have you a little while longer. And Elizabeth, to you and Trudy, thank you. And again, for the outstanding 2,000 other nurses, I couldn't help but think as I was listening to you, I'm back here taking throat medicine because I got a sore throat, and I go, I got the greatest nurses in the world right here. What am I doing back here taking throat? Thank you again, and well deserved. I mean, Wanda, I know you kind of say everybody else does it. It takes fantastic leadership. Thank you for what you've done. Thank you very much.
Thank you.
Thank you.
Mr. Chairman, that concludes my report. Thank you.
Super. A very good report, Robert. Outstanding report, actually. Brings us to item number 8 on the agenda. Normally I just say item number 8. I'm going to take a moment. This is a special, we haven't seen this on this agenda, and I guess the 7 or 8 years I've been on the board, look around this board. Many of you have been on this board longer. Some are new with Dr. Simmons coming on a couple months ago, but I'm going to read what item number 7 says. It says, consider approval of the resolution in support of a bond election for the purpose of acquiring, constructing, improving, equipping, and enlarging facilities in the Tarrant County Hospital District system. That's what those words say. And driving over here today, knowing that was on the agenda, we don't have some big fancy presentation. The resolution has been presented to the portal. I know all the Board of Managers had an opportunity to read it and any questions you had. But it made me stop and reflect a moment in thinking that, I'm just the occupant of the chair currently. But the last actual bond package for the district and JPS was in 1985. And I thought, as I drove over here for this meeting today, I thought, in over 30 years, I think of all the outstanding Board of Managers that served on this board. There's been needs to the mission and those kind of things. I think about all the board members that have been on here, people I can't even remember. Former chairmen, know most of them. I look in this room, we have 3 former chairmen sitting right here. I'm very humbled to be sitting in the chair now. There's 3 of them sitting at this table right now. A lot of work has brought us to this, what seems like something very quick on an agenda. And I think it's one of those times in the history of JPS, it's a very unique that this board has a chance to truly show our support and endorsement of what the Commissioners' Courts we hope are about to move forward with. So, I reflect back, it was just February the 27th. We brought this board together with the Citizens Blue Ribbon Committee along with the Commissioners Court, and heard all the recommendations from the Citizens Blue Ribbon Committee. We've been waiting for been over a year since they'd been appointed. A lot of work's been done. There's been tremendous amount of due diligence behind what seems like a simple yay or nay. And so I appreciate you, Robert, and the staff. I'd be remiss, I see Mr. G.K. Maina sitting in the audience as county administrator with the Commissioners Court. He's come to this board several times and made presentations, and certainly to the entire board of managers. I appreciate there's been numerous additional workloads, both in Trent's area as chair of planning and both in Steve's area is in finance, and I appreciate their excess work. Also, you may recall Trent actually served on the Citizens Blue Ribbon Committee. Dr. Simmons did. He wasn't on the board at that time, but he likewise was a member. And Dr. Lowry, who was previously on the board, served on that committee. So we've had a lot of interaction, but you know, really since about February, this has been moving forward. There's been a lot of meetings. I just want to thank y'all for all the time and effort you've done and been a part of. And I'll end on this. There's several of our board members that started this road with us in the last 6-8 years. They're no longer with us. They're no longer with us because they're off the board. They've passed on. And so there's a lot of history and a lot of time comes to this particular moment. So again, that's my reflection. I appreciate all the work everybody's done. I think we're at that point in time where, again, it's easy to say item number 7's on the agenda, and I will certainly open that up for any discussion. Again, I know everyone's had previous times to see the recommended resolutions, and so again, I open it up for any discussion or any comments.
Mr. Chairman, I'd like to make the motion, and if there are any discussion, then follow that up and say that on behalf of those that not only served on the Blue Ribbon Committee but have been on the board a long, long time, Steve, Chuck, Charlie, we all sort of started together, and Steve was kind of our leader at the time. This has been a long time coming, and it is a process that I think has been publicly vetted very well. I think there has been a great deal of time, brain power, prayer, everything you can think of to put us in the place that we are today. So I appreciate your confidence in planning to be able to vet this and bring it forward. On behalf of all of us that have had a chance to serve on the JPS board, the Karen Van Wagners of the world. Right. This is a time that has come, and it's an honor to recommend that this resolution be approved.
Reverend Emerson?
Mr. Chairman, I'd like to also second Trent's motion. Okay. It's exciting to do this today. It's one of the things to see it, but now to see it is a blessing. So I second that motion.
I appreciate that. I'll ask General Counsel, does the entire resolution need to be read in? We have copies. Everybody's been provided? Not unless one of the members wishes to be read. Then everyone's certainly been supplied a copy. I have a motion on the floor. I have a second on the floor. Is there any other discussion? Is there a dollar amount that we're looking at, or what are we looking at? No, DT, there's not, because we don't actually set this. This is our support of what the commissioners would do. We don't set that number. Any other discussion? There being none, I would call for all those in favor say aye. Aye. Opposed, no. Have the minutes reflect it passed unanimously. Thank you very much, and thank y'all. Again, it's a simple thank you. GK, again, there's work to be done, but we certainly are looking forward, and I think you just heard this board supports fully the direction hopefully the commissioners will go. We certainly don't know where they're going, but we hope they're going where we think they are. So, I want to thank each and every one of you. Well, thank you. No. Moving along, item number 8, Dr. Schrader, are there any comments from the medical executive staff?
I'm just wondering whose idea it was to put me right after this monument. So
congratulations.
Thank you. I refrain from any comments per se, okay. For the sake of time. I do have a request to the board in terms of action for their moderate sedation clinical privileges. Okay. That is in your packet. I need approval from the medical staff.
I have a motion by Dr. Weber. Second. I have a second by Dr. Simmons. All those in favor say aye. Aye. Opposed, no. Passes. Thank you very much, Chet. Thank you very much. The next item is the acclaim. I've been advised in discussion, Dr. Hoffberg and obviously Chuck that we're going to move that forward to next month for any updates, so we appreciate that. So we will move forward. Brings us to the committee reports, which is item number 10, the first being finance. Mr. Montgomery, Finance Committee met on July 26th.
Yes, sir. So the Finance Committee met on July 26th. We reviewed the June financials, and there are several contracts that are on our consent agenda today. That concludes my report.
Okay. All righty. And would Ms. Clark come up at this time for the monthly financial summary? Good afternoon.
How are you?
Thank you.
So for the month of June, our performance came in right at budget or ahead. If you look at the hospital, we're actually about $240,000 favorable with a break-even month. Acclaim continues to be right on budget as they have been for the entire year so far. And if you look at the total amount, you can see that consolidated, we actually performed about $263,000 ahead of budget. Year to date, let's see, I can't draw on that side. I've got some block there, but year to date, we have, we're behind our budget about $1 million. We've still got 3 months for this fiscal year. But bottom line, on our net income, we are only about $77,000 behind for 9 months. So it was a positive month compared to budget. Are there any questions for June? Okay. Thank you.
All right. Steve, anything else from finance? No, sir. All right. Then, we don't need an approval of that, do we? No, we're fine. Report. Which takes us to item number 9, which is, I think Miss Wanda's coming back up. Miss Peoples coming up, and she didn't move from 42 years to 43 years, just in that small time.
No, she did not.
Just want to make sure.
Hello again. I am here to present a contract today for consideration of approval for our Alaris infusion pumps. This is replacement of our whole pump fleet, which includes our regular IV pumps, our syringe pumps, and our PCA pumps. The current pumps we have are over 10 years old, or the majority of them are over 10 years old, so it is time to replace those. So this is part of our contract. It did go out for an RFP. 4 different companies responded. We brought those 4 companies in, set them up here in the auditorium on different days, and let the clinical staff, physicians, anesthesiologists, any stakeholders look at those. And they landed on this company, Alaris, which is what we currently have in-house, so it wouldn't be a big learning curve for the staff. So.
Yeah. Steve, I think you had a comment too.
Yes, sir. I just wanted to thank you, Wanda. This would normally have gone through finance, but it was a timing issue, and we actually got a financial break by acting quickly.
Absolutely.
So I thank you for that. We want to go ahead and move this
directly to the board.
Wanda, again, I think the point Steve's making is the point I likewise going to make. Obviously, we would normally say this has been totally vetted through. It did get all that, but I heard you say there was some kind of savings if we went in and got this done today by the board. That savings was how much?
Over $1 million.
That's about $1.6 million.
$1.6 million.
So again, that's why the board, this is coming directly to the board, because there is a time element here should we miss that window. So I appreciate Steve getting with Wanda and staff and all that. I mean, I think it would have gone through the normal process and come to the board. We always say things have been vetted through committees before they come to the board. This one is coming direct, and the reason behind it is what Steve just said. Anyway.
Mr. Chairman, your motion too is not only approving the customer order that takes advantage of this savings, but you're also approving a First Amendment to the master agreement, which brings that master up to agreement compliance with a new state statute. So,
Mr. Chairman, I move approval.
I have a motion. I have a motion by Mr. Montgomery, second by Reverend Emerson. All those in favor say aye. Aye. Opposed, no. Again, Wanda, thank you very much. I'd like to hear savings. The next before you is the consent agenda. As you know, all those items have gone through the necessary committees, been voted on. I think I say this each month, just for those who might be attending via call-in or via the tape or via the streaming. Anyone on this board, and many of you do, attend not only the committees that you have specific assignment to, you attend any and all committees, and I appreciate the time service, but each one of these have gone through the necessary committees, have been vetted, moved through the process, whether it's from planning to finance to wherever. So if there's any discussions, we would certainly pull one off for discussion. If not, I'd entertain a motion for the consent agenda.
Second.
Got a motion by Dr. Weber, a second by Mrs. DeBose. All those in favor say aye.
Aye.
Thank you very much. I'll pass. Moves us to item number 13, which is our legal service. I'll look to General Counsel for any comments there.
Yeah, Mr. Chairman, for the month of June, there were 24 contracts negotiated under $200,000. Those have been listed on your board portal. And there were 5 contracts negotiated between $200,000 and $500,000. Those also have been listed on your board portal.
If anyone should have any questions on those, seeing how they were on the board portal, we would move along because no action is necessary.
Correct.
That's a report by General Counsel, which brings us to item number 14, which is, Mr. Montgomery, I'll look to you as Chair of Finance. I know that we're going to have a presentation by Mrs. Clark. There are 4 items listed under item number 14. I think the presentation will go along and then you can decide, but we will ultimately need to vote on all 4 of these separately.
Yeah,
so I just want everybody to know there may be some overlap as we talk about the general budget or whatever. So Steve, I'll turn it over to you and to
Sure.
Sharon.
As Sharon's coming up, I think everyone's had an opportunity to visit with Sharon and look at her proposal today or her outline today, and had an opportunity to submit questions, so I appreciate that. I like the format. I think it's very intuitive. I've talked to several of my colleagues, and everybody seems to be digging it, so let's stick with it. Like you said, Mr. Chairman, there's 4 sections of this. We'll have to take them separately, but we'll probably talk about them in tandem, so.
Okay.
Mr. Chair, before, I'm sorry.
No.
Before Sharon starts, dotted throughout the audience are members of our finance team. And these are people that, I mean, they sign up for it, but still when you sign up for it and you feel that brisk wind, it's tough. And the amount of time that they've given, the amount of time that it takes to put a budget together, just to redo the numbers, because all of a sudden we got page 10 was supposed to be page 11. You go through and you redo the whole thing, or we hit suggestions, or we go through that. Sharon and her team have done yeoman's work on this, and I appreciate it. No matter what you feel about this budget, the amount of work and effort that goes into it by a CFO and by her staff is pretty amazing, and I'm proud of them, and I'm proud to work with them. The other thing is everybody on the team, from the individual that came on to JPS 6 months ago to the individual who's been here for 40 years, they've done an incredible amount of work going back and looking at this budget. This budget was a challenging budget because when you're off balance a little bit by supplemental funding from the federal government, it's challenging to come up with what you need to come up with. So I'm thankful for the employees at JPS for all the work they did. And the last compliment I want to give is to y'all as board members, because Sharon set up time for y'all to have sort of the phone-in kind of session, so you could phone in. If that time was not available to you, individual questions that y'all have. So some of you that had gone into more detail, I know that in Dr. Weber's case and in Dorothy's case and in DT's case, we appreciate that diligence that y'all gave. The work that we have Chairman of Planning and the Chairman of Finance and Chairman of the Board went through in individual briefing sessions. So for those watching live streaming and those in the audience, I don't want you to think that the amount of work is going to be represented today. The amount of work that went into this is represented 6 months prior to this. And Sharon's job and the team of finance is much like painting the San Francisco Bay Bridge. When you get painting it, you get down to the other side and you start painting the other side, and you just do that continuously. So we will, depending on what you all do with the budget today, if it is a situation that you think we should move forward and you like this budget, Sharon has agreed to give her staff this evening off, and then tomorrow at 8 o'clock, they'll be back in to begin their work again. So we're proud that they'll be able to have a dinner tonight with their family. But I do want to thank you personally, Sharon, and your team for all the amazing hard work that you put into this.
You know, it is a logistic issue to get everything kind of pulled together, and it always happens in the last 2 to 3 weeks. But almost every JPS employee behind me has worked an inordinate amount of time through the budget process. It's not, from my perspective, the budget is not a finance function. We work with every leader and talk to a ton of people. We don't make changes to this budget without involving the operational folks. So rest assured that everybody in this room knows exactly what is in this budget and has seen it before I start to present it to you. So thank you for the kind words. Before we start the presentation, I am going to assume that you've had a chance to at least glance through the budget presentation. If not, feel free to slow me down. I may also assume that you might know something that you don't, especially Dr. Simmons. This is going to be a drinking from the fire hose for you today. But for this budget, definitely our biggest challenge was trying to come up with a strategy on how to correct the financials for the changes that will be coming for our federal funding. At Finance Committee last month, a couple of weeks ago, we talked about what is that number going to be. If you recall, we expected to have about a $12 million decline from 17 to the 18 budget. You know, that happened kind of at the last minute last year, along with some other changes. And now we're talking about another $13.3 million from that expectation to what we're actually going to be receiving in September, October. So, and I did my best to try to explain this to you on the very first page of your presentation. But, you know, from one year to the next, we actually receive about $62 million a year net for UC. And just from budget 18 to budget 19, year to year, we're going to have a loss of close to $38 million. Now, we planned for some of that. The other is kind of a surprise, and you may say, well, you know, why could you not have anticipated this a bit more? Over the last few months, Texas Children's actually filed litigation years ago that they were asking that, based on the way the legislation was written for this federal funding, that you should not have to deduct secondary insurance payments from your cost of uninsured. Whether it had merit or not, it has been in the courts for years. That ruling came out a few months ago that agreed, based on the language within the law, although that may not have been the true intent of the law, that indeed that's how the calculation was going to work. So what it did is it increased everybody's hospital-specific limit, or their cap, of how much UC you can do, and it also defines proportionately what gets distributed. Even though the hospitals, the public hospitals, the large public pool increased by 10%, the private pools increased by over 60%. So as we have continual discussions about federal funding and how all of those pools work and the step-down methodology of the allocation, even though our hospital-specific limit increased, proportionately we're getting a smaller piece of the pie. So that is where the number that we're talking about today is coming from, is that one change. So you'll see that 13.3 million, which is kind of the impact again from the settlement of this case, and it's going to come out of this year's distribution as well as next year's for budget 19. Now, it is not as if Robert has not been involved in conversations with HHSC. And about 2 weeks ago, we have received notification that the UC payment for this year will be delayed a bit because they are re-looking at the allocation and the unintentional distribution, that redistribution of the pools that has occurred with some recent events. So that is all of the information that we have. We will continue to work with HHSC and trying to understand the formula funding better and how it's applied during the future. So does anybody have any questions about that? It's a very complex issue, and I've tried to tell you about it in 5 minutes or less, so I'll be happy to go back over that. Sorry, I'm having a slow click today. So just as an overview, and I'm not going to get into much detail here because we are going to go through the medical center, then I'm going to go through a claim, we'll cover the foundation, and then we'll come back to the overall income statement. I've done it different ways over different years, and I think it's better when you have a good overall picture before I start to get into some of the detail. So on the first column, the JPS Health Network really represents the entity that is the hospital and all of our outpatient services from a facility side. So this year, and this number includes the reduction of 13.3 million. So we have budgeted for that to keep our UC payment at about $38 million. So we were able to generate enough margin to cover that for budget. That gives us about a 0.7% return from an operating margin perspective. You can see that our bottom line after interest income is about 23 million or 2%. The second corporation that we're going to be talking about is our physician network, which we call a claim. And currently they are budgeted at a $23.6 million loss. Again, we're going to go through that in detail, and we'll start to look at that loss by physician, which I think is really helpful. And then our foundation continues to fundraise at about the same level it did last year, and it contributes $776,000 to our overall performance. So when you combine those three entities, we are right at a $16 million loss. After our interest income, we are at a break-even budget of about $271,000. So I'm going to jump into medical center. So I'm going to talk about a few things here that you're going to see continually throughout the next few pages. These are either new services that are impacting revenues and expenses. They could just be strategic initiatives that we are working on this year as well. But the biggest and most significant, obviously, is the change in the federal funding that we project to happen this year. Also, a big part of our revenues are our property taxes. Those are increasing by 9.8% this year. We're going to have a full year impact of the way that we access our federal funding, which is URIP. That impacts both the revenue and the expense side this year. That started, I believe, in March. As always, we continue to try to improve our revenue cycle, collect from our insurers what is due. We're also looking at denials management and how we charge. A big focus in the nursing area and in case management is utilization and care coordination. We were able to add 9 inpatient beds on an existing unit by doubling up beds this year, so hopefully that will help alleviate any ED and help offload some of those inpatient waits. We're also creating additional beds in the admission holding unit for that, so you're going to see some staffing impacts when we get to the salary expense. There's a new program for that we have some retail partners that help us expand our 340B program, and I'm going to talk a little bit more about that when we get to the revenue side. We are also currently and continue to benchmark operational costs and staffing costs. Our Northeast Medical Home is going to be opening in October. That has been under construction for the better part of the year. And we're going to begin mobile mammography screenings as well. I think that service kicks off in January. Okay, so from a statistical standpoint, these hopefully look really familiar to you. I present these statistics each month in my financial report, so I'm not going to cover these in a lot of detail. For the most part, we have budgeted fairly constant volumes, both in inpatient and outpatient. For the inpatient stats, you're going to see that increase, and there's two components that have allowed us to increase our admissions. Number one is that additional 9 beds up on E3. And number 2, we are going to look at documentation and the appropriateness of an OBS patient versus an admission, an inpatient admission. So we feel like there's some opportunities to take those holding patients and actually create an admission from them. So these are not necessarily extra beds that are needed, but it will produce some appropriate payments for those patients. Patient days closely follows. Our outpatient statistics, both of our urgent care and our ED is really very busy throughout the year. And although we're having a slight increase in urgent care, it looks like up there, when we started to look at stats, that's relatively flat. And then our ED is at capacity, so we kept that level as well. From surgery, you can see here, again, our intention for our inpatient service was flat, but they have been very busy the last few months. So it kind of looks like a decrease, but we will continue to focus on that. The outpatient surgery growth is larger because of what we expect to be done out at our Arlington Surgery Center. We've got a couple of new physicians that are operating there and have increased the numbers that we are expecting. Primary care visits and specialty care visits show a modest increase. A lot of that, when we get to a claim, you will start to see that we've onboarded a lot of physicians this year, but we're not expecting necessarily, we're not budgeting to onboard new physicians. When we determine that those volumes are requiring a new physician, we'll be proceeding at that point in time. So our outpatient statistics are fairly flat. behavioral health on the next two slides. We have patient days for behavioral health, again, fairly flat. We are at capacity for most of this year. And the psych emergency visits, we are keeping flat. Clinic visits on behavioral, those were intended to be about flat, so we're showing just a 1% decline, and then partial hospitalization is constant. So that should tell you that we're not going to get a large increase from volume, except on the inpatient side, where we have figured out how to get a few more beds. So when you look at the top of our income statement, there's a lot of numbers that are going in, but we can put them into one of these four slices of the pie. Our biggest number right now is at 43%, the patient service revenue. That is billings that we collect from either patients or an insurer, such as United, or Blue Cross, or Medicare and Medicaid. So any of those patient-generated services are included in the blue slice of the pie. Ad valorem tax revenue, even though it is a very significant part, only makes up about 40% of our total revenue. And then the federal funding slice of the pie is continuing to get smaller and smaller. This year, it comprises just about 12% of our total budget. And then we do have some other revenue, the largest portion being our tobacco fund that we get from the state. Payer mix, we're not expecting any major changes in payer mix. One thing that you might want to note, you kind of have to add this gray as well as the green together to look at what patients are truly unfunded. So we have budgeted about a 39%. And this pie chart is actually based on gross revenue or total charge, not the collections on the patient, or else those slices would be tiny. And at least in my experience, a self-pay uninsured population of a non-public facility is probably somewhere between 3 and 8%. So we've got a much higher rate at 39. But to point out, we do have 12% commercial. Medicaid is a large part with 23%, and then you can see the gold shades for our Medicare. So here's the numbers after we talk about where things come from. I'm going to walk through those four big pieces of the pie. We have net patient revenue of about $440 million. So again, those are dollars that we collect mainly from insurance companies and or Medicare and Medicaid. That's going up about 8%. The biggest driver of that is the way that Medicaid managed care pays us for the URIP program. If you have any questions about that program, I'll be happy to answer them. But we get a higher payment through the state. HHSC kind of pushes those federal dollars back through the HMOs that participate in Tarrant County back to us. And you'll see the IGT expense on the other side. But because of that full year impact, we're going to get about $10 million more for Medicaid. Our Medicare, on the other hand, pays us differently than Medicaid. Medicaid really focuses on a base payment, and then we go through all these federal funding pools to get additional monies that Medicaid feels like it needs to get us, such as the UC, DSRIP, and any other funds that we typically discuss. Medicare, on the other hand, pays DISH and UC on a per claim basis. So that inflation actually produces about $6.8 million more for us. We also had the volume increases that we were talking about from the progressive care beds and that shift from observation into inpatient. That's going to be about $4 million. We contractually have the ability to do kind of a cost increase on our charges, and the charge master increase that you see of $4.3 million comes mainly through the commercial insurance plans that we're contracted with. It's kind of a cost of living, if you will. And the rev cycle, like I mentioned on the first slide, we are constantly trying to find ways to improve how we charge patients and how we collect on the back end. We were successful in a new managed care contract that produces some additional revenue for us, and the appropriate admissions will be a focus this year as well. Are there any questions on the patient revenue side before I get into the tax revenue? Okay. Our taxes are, again, kind of a complex issue for us. This year, there was the Tarrant County Appraisal District valued property at $187 billion for our tax roll this year. That's about a $16 billion increase, and 25% of that was brand new property in Tarrant County, so $4 billion. That comes from residential, commercial, industrial, and personal business taxes, personal property business taxes, as well as mineral and agriculture, which makes up just a small part. Even though we are increasing our collections by 9.8% this year, the effective tax rate is 5.1%. So that's an important number to also have. This slide is fairly complex, but it will be something that you're going to be voting on if you choose to make that motion. So I think I need to point out a couple of numbers for you here. This is our current tax rate. It's 0.224429. It will remain unchanged from last year. And we go through a calculation, but our bottom line number is $413.7 million of funding. Last year, we received about $377 million. So there's our increase. This is broken out between maintenance and operations, as well as the interest portion. The interest portion is calculated based on the debt that we do have outstanding, and we have a debt service schedule, so that number changes, but the balance goes into the M&O rate. Any questions about taxes? Okay.
Last year, when we were here at this spot, the question came up about lowering the tax rate. Trust me, I'm not taking on that plight. But have you calculated or looked at the impact if such a thing would happen per penny? We cut the tax rate.
So last year, because of the effective tax rate, I believe we were asked to look at the base rate. We limited ourselves to a 5.9% effective rate. The legislative limit is an 8% before you start to go through a rollback process, which is a recalculation of your base rate.
Right.
When we cut 1/4 of a cent from this number, it cost us about $5.4 million last year. Does that answer your question?
Yeah, I just wanted to have that ready just in case that comes up again.
Yes, sir.
It's about 5.4 per quarter. Yeah.
And it's really 1/4. It's a math exercise, but the 1/4, it's actually 1/4 per 100, I believe. And so last year it was those two numbers that changed. So it's 1% of a penny.
So if we have to do any rollback, is it possible that we could ask the chair of the finance committee to cover that cost?
If that's a motion, I'd entertain.
You're welcome to.
Yeah, no, he knows that wouldn't work. He got it. He does. That next slide's what it tells you. Look at this one.
Yeah.
So the federal funding, again, is made up of 3 large components. We do have the Europe program, which kind of sits to the side of these 3 things, but UC and DISRIP, so the first and the third line there, are what we call the 1115 waiver because Texas did not go through a Medicaid expansion. DISH, the orange bar, has been there for years. I think at least since '93 in a large way, and prior to that it has been around probably for a decade. So these 3 components are what make up the federal funding, kind of the Medicaid shortfall or our costs for a disproportionate share of self-pay and unfunded. And you can see that from 2015, we had about $182 million. If you look at the budget in 19, that total amount is just under $120 million.
Right.
So there has been a pretty drastic shortfall. There are two charts in here for the 18 year. The first one represents what we thought would happen in budget, and this is our revised number showing that gap that we are expecting. So again, between these 2 numbers, sometimes I'm good and sometimes I'm not. Between these 2 numbers, this is about 31 million, right?
Yes.
And then here is where we get our 13 million. So those are very drastic cuts. And again, both of these charts are 18. One is just adjusted for what we know today.
And even excuse me, Steve, what you all are going to have to deal with, and we as the staff are going to have to deal with in the future, is how we begin to think forwardly at supplementing those incomes. Because I'm the firm belief that greater lobbying and more screaming and making our point more valid is not going to restore those federal dollars and increase those federal dollars. I would be happy if that were to happen, but that's not going to happen. So I think what's going to face you as a board and us as a staff in the next 5 years are questions and answers that we've not asked before. Questions and answers that lend ourselves to our relationship with the private sector, our relationship with our payer mix, our relationship with what we do with our real estate holdings. So you all, through Planning Committee and Finance Committee, will begin to get more issues confronting you all that will put JPS in a different place. And I think our answer, and there are answers to that loss, are some innovative approaches that we've not discussed in the past, but it's a new day. And thank goodness that the legislature has given us the ability through a variety of programs to do those for public hospitals. So that's more that's not woe is us or we got to go fight harder in Washington. It is, we understand the circumstances, and it is a new dynamic for JPS.
Robert, if I could just say one thing, and again, I don't have a mic, but I certainly, I agree with everything you're saying. We've talked about everything from research to other, we've got to look at those additional revenue sources. But again, as I told Sharon when she graphed this is so, when you see it, you look at almost, was it $60 million over the last 5 years? Because you remember there's 218 sitting in there. So it's about a 5-year. We also managed through all that, lost close to $60 million worth of revenue sources, and yet we maintain a AA bond rating by the rating agency.
S&P.
By S&P. So again, it just didn't, like you say, it wasn't just, oh, woe me. This board and previous boards and the chairs during all that time, we managed through that, and it was not necessarily all that easy at times.
Well, and to my point, Charlie, is what you all will see that will percolate up through the next 12 months to the next 5 years is ideas that we have at staff to create productivity, efficiencies, and new models. We need to look at this organization. It's a large organization, and we need to make sure how we're doing things are efficient, and we need to also make sure that we're not making such drastic changes that you interrupt the kind of patient care that we've been providing here, and you interrupt the relationship that we have with our taxpayers that I think have become a trusting relationship that we have with them. We have a patient base that's continuing to come into that front door, and we need to serve. So you all will be hearing within the next 2 to 3 months new ideas of productivity, new ideas of efficiencies, so that we can continue to look at that. I want you all to think about this budget in its organic nature, because we will be coming to you constantly with changes that we would suggest that we can increase that productivity, efficiency, and new models.
So just another view, kind of a cleaner view, I think. As I mentioned earlier, we are budgeting about $38 million for UC. That is kind of the average as we talk through it with Mike Spivey on where we think actual 18 will end up. It could be as low as 31 million or as high as 45 million. So I just took the middle range of that number. For disproportionate share, we are expecting a slight increase in the 19 budget due to some calculations in the way that that formula is working. Our cap will increase just slightly. And then with DSRIP, you can see that even though we are moving into a new DSRIP program for 18, the budget in 19 is fairly consistent. Other non-patient revenue, we have, this is pretty much, this is where everything lands that is not a collection of property tax or a collection from an insurance source. So there, there's a lot that comprise this $52 million. One of the largest pickups is going to be that expansion of the 340B retail program. And this program allows our patients that do not fill here, when they fill at a partner, who I'll talk about in just a minute, it allows the access to the 340B pricing for prescriptions that are written by JPS physicians. So some of our partners are CVS, Walmart, Tom Thumb, and Albertsons, along with the CVS specialty program, and then with Walgreens, both their retail and specialty. So as we looked at the information that we have on where the JPS patients are actually filling prescriptions, it's mainly within Tarrant and the surrounding counties. So you see 2.4 million, but there's quite a bit of drug cost associated with that. So you're gonna see that on a different slide of about 800, and we're also gonna talk about the administrative fees that have to go along with that. But that program does net us about $1 million in this year's budget. We also have a small increase in the PAP program. You'll see that as an increase in expense, so that's a net zero. We have we kind of, for Ryan White, that helps funds our AIDS program and our HIV clinics. We had a great success this year in accessing some additional dollars. We've applied again for those additional dollars, but until those come through, I was not comfortable putting that into the budget. So those dollars may come back to some extent, but it was kind of a special windfall, if you will, in fiscal year 18. And then one item that created a negative in our budget is the tobacco fund. So for the last biennium, the state of Texas allocated some of its discretionary funds to the tobacco distribution. And I'm not sure that that's going to happen this year. So we got about $1 million more this year and last year than if you look at the trend before that. And it is based on how much property tax revenue that the facility receives. Again, this is one of those proportional distributions. So I have taken it back down to a historical level, and hopefully the state will reallocate those discretionary funds. So that's kind of a recap on the top side of the income statement. And for the bottom side, I'm going to just roll down each line item for you. Salaries and wages are going up about 4%. A lot of that is coming out of contract labor, but total comp is going up by about 3%. In talking about contract labor, when we do our budget, we assume that all budgeted positions are filled for the entire year. That doesn't happen, so we sometimes have contract labor, especially for management positions. Most of the staff positions are filled with a pool or overtime. Someone picks up an extra shift. So most of that contract labor in projected 18 is for open management positions that are now full. So we took that number down. And then in salary and wages, we are projecting a 2% average merit increase. Employees can get somewhere between 0 and 3% depending on their evaluation. Again, I did budget to have full staffing as well as that offsetting reduction of contract labor, but that adds about $6 million. We do have a few new programs that I will talk about when we get to the FTE slide. We have market adjustments every year, and the market adjustments that we did this year are going to have a full year impact as well as next year's market adjustment. We are focused on a length of stay reduction. Right now we're right at 6 days on average in the medical center. And by hopefully focusing on discharges, we can reduce that, and that is the amount of staff cost that would be saved by that reduction. The last item is a benefit that hits salaries. Currently, we allow employees to sell back 160 hours of their paid time off. This comes twice a year at 80 hours each, and what we're proposing for next year is to encourage staff to take off their paid time, and we're going to limit that sell back to 80 hours in December. So we're going to close down that second PTO sell back period, and that will save us about $800,000. So for benefits, if you guys recall, over the last 9 months, there's not been but about 2 months where I have not reported a very significant overage in our health insurance cost. So as we look at the ways that staff access their own health care, and healthcare employees are very high utilizers of healthcare, right? We know who to call, we know how to access it. We want a specialist to see us before we go to our primary care doctor because, you know, heck, they might be my board meeting. So what we looked at is how do we start to redirect care? How do we educate employees on the right way to use it, the right place, the right time? And the marketplace for the last decade has been going more into a high deductible health plan. And we're gonna couple that with a health savings account as one option that employees can move into. We will keep our traditional PPO that quite honestly has a very high withhold from each paycheck for an employee to participate in that. If the PPO, if they move from a PPO to the HSA option and the high deductible health plan, it'll actually be about a 30% reduction in their monthly premium. Now, hopefully they're gonna take that savings and put it into the health savings account to where you're building up a savings account to pay for your own health care. If you move from the choice to the HSA, or if you stay in the PPO, your premiums will slightly increase. So we're hoping that staff will move into this high deductible health plan option. It's really appealing to people who don't access their health care too much, and it also, before you walk into urgent care, you may think about, you know, taking some over the counter, perhaps decreasing that utilization. We're also proposing the increase in employee contribution for covered spouses. Again, as we look at what's causing some of the really big overages, the large cases month to month, we have a disproportionate share of high claims from spousal coverage. So in order to make sure that the utilization is being paid for by those employees who are insuring their spouses, we are going, it's about $83 a month on average that this will go up and help offset some of those escalating costs for spousal coverage. And we're also going to adopt a nicotine usage surcharge. Did you have a question? No. We're going to adopt a nicotine usage surcharge that is about $50 a month. It's a question as we sign up for our health insurance if you're a tobacco or nicotine user. If so, your health care will cost $50 more each month. And that's a pay period deduction, so it's right around $25 per pay period.
Sharon, if I'm a nicotine user at JPS and I'm frustrated by that and I'm not pleased at all, so I want to go somewhere else where they don't have that, is that a majority of places I'm going to go or a minority place I'm going to go? Minority of places.
I've been working with our healthcare consultants to try to figure out who is assessing a tobacco surcharge. One major player in the DFW area is. I know that one is considering it but has not yet moved there.
The options on the high deductible, I know there's a presentation here to the board, but have we done this presentation to the employees and have we gotten some type of response back in reference to that?
So I believe that we are preparing for those meetings with employees, and this high deductible health plan option, it does require a lot of education. Personally, the first time I went to a high deductible health plan, it took me about 3 months to really get into the understanding of how the plan works and where the employee pays versus when the health insurance pays. So the high deductible health plan, it's not necessarily any more out of pocket. It's just you have to access your out of pocket early in your plan. So instead of a copay, you may have to pay the $45 charge that your primary care physician assesses when you go see them.
Okay.
To your point, Pastor, tomorrow morning, we start our town hall meetings, and we go from 7:30 a.m. until 6 p.m. on the hour. And then we have a town hall meeting on Saturday, and then we have town hall meetings on Monday for our employees. In addition to that, Drs. Kramer and Schrader will start town hall meetings with our physicians, and that starts in 2 weeks, if I'm not mistaken. And one of the things that we want to do with the deductible is allow our employees still to have the ability to make a decision. It's one thing if you say, okay, here's what we're going to do. What do y'all think? Or is it a matter of educating them to say, here are now the options in front of you? And you have more options in front of you, whether you want them or not. You can go this way, or this way. This we see as more an educational process, and that is we're offering them something that we think could be beneficial for a lot of our employees. It'll change their deductible as they want to see, or they can keep the program they're currently in. So this now becomes more an education rather than going out and saying, do y'all think we should do this? We did not go out and say, do you think we should do that? Because hopefully we're not taking anything away, but we do need to educate our employees also to help with a program that we think is helpful to the budget and helpful to them. And we learned our lesson because about 5 years ago, we didn't give options, and we just said, here's the new plan, you like it or don't, and they said, we don't like it, and we felt that significantly.
Yeah, that's why I asked, because I remember that.
Yeah, that was not a happy time.
Right.
Not a happy place.
Other part that I have is, I know there are probably some plans in place on educating the employee or encouraging the employee as far as taking care of themselves. Or we have, maybe exercise programs or workout programs or whatever that is that they don't go to see the doctor a lot. So
yeah, so our HR department has a lot of wellness initiatives.
Okay.
We also have a wellness program that you can earn up to $500, I believe, back to credit, either to begin your HSA or just to offset your cost of health care. So if I meet certain criteria throughout the year, if I do my, if I have my basic health care coverage, mammographies, if I complete surveys, if I go to a healthy cooking class, if I get my BMI testing at the beginning of the year, I get credit and points for that. And at the end of the year, I can earn from $250 to $500 of a wellness credit that helps me with my monthly premium.
And then you can apply that again.
Quick question.
Yeah.
Is this program being run by the plan administrator or HR or Dr. Duncan's group?
No, this is a Cigna option for our employee self-insurance program. So we'll have the PPO and we'll also have this program as a choice.
Do they work with us on now the network for specialists and all that stuff also?
Not just this program, but any of our employee health insurance has JPS identified as kind of the providers of choice. And it is a deeper discount, less cost to the employee. You meet your deductibles faster if you're within the JPS network. We have a second tier, which is broader for Tarrant County. And, but yes, we try to encourage staying within the JPS health network as much as we can.
Hey, Sharon.
Yes.
Have we, when you talk about the large spouse utilization, have we looked at requiring spouses to access primary insurance through their employer?
We have, and that actually is part of the discussion. Right now, we don't want to mandate that, but I think this surcharge will create that conversation at the kitchen table. If, you know, if your it might be cheaper now for them to go through their own employer, and that's what we would encourage. As a reminder, JPS, you know, Cigna is not at risk for our health plan. We're actually a self-funded health plan. So as our employees and their families access care, that cost of that care is what comes in through my employee benefit expense. So every dollar that Cigna pays out, they bill me for, and I fund the account effectively. So education is certainly a big part of that, but rather than say what you were suggesting, which a lot of people in business do today, we're just going to try to have them carry a proportionate share of that spousal coverage.
I'm just wondering, at what point do we merge our employee plan and our population health plan for our JPS connection together? Because it's, you know, you're still doing the same thing, you nail the network, you look at the prescription, all the program together for a healthy environment. So maybe there's now some opportunity down the road to do the same thing, but separate the privacy issue out.
Okay.
Sharon, on the spouse, if you have your spouse on your coverage, if they follow the wellness plan, do they get any points for that, or is it just on the employee?
No, just the wellness. The wellness only applies to employees. There's just a limited amount of effectiveness on the requiring employees to either fill or non-employees, other covered participants, on filling out wellness information or participating. So due to the cost of the program as well, we've limited that to employees only.
The reason I brought that up, if we are spouses is the one that's costing your cost to go up, maybe we ought to look at how we
Let me rephrase that. They have access to the wellness. They do not get an additional 500 of credit.
I wouldn't think that
they do
you'd
have
be,
access to the care management and wellness.
I wouldn't see that they would get anything, but if I could get my spouse to come and do all the things, maybe there would be a portion increase for me as a family if I got all of those things done, because it would reduce your overall cost. That's what that's all I'm suggesting.
But the leakage is costs more to go to outside provider. It costs a lot more.
Yeah, but I'm thinking that if you're encouraging since I'm thinking most of them are females, they're gonna decide where the husband going anyway. So if you were saying, we're gonna incentivize you to make sure that your husband complete his surveys, and if he does this thing in your service plan, you could get a little bit more. You could be, you know, I'm not saying 500, but something. I guarantee you that those females that's helping with those decisions would start ensuring that more annual physicals are done and surveys are filled out. Okay. That's all I'm saying.
I have a question. Do we periodically look at the network that we use to provide care, like the Cigna network, compared to others and the contracted rates that we're paying to make sure that what we have is the most beneficial for the network?
I was not part of the RFP process, but that went out to we actually did a look this year on our plan administrator, and Cigna was reselected. So I think that was just recently done.
Is that something that's done every year or every couple of years? Or?
No, it's definitely not every year. I would say about every
I think every 3 years, every 2 to 3 years.
2 or 3. Bill's saying 2.
There are substantial differences in what the payers pay, which if you're in a self-funded plan, like apparently we are, that can translate into what we're actually paying dollar-wise for healthcare.
And that would have been part, I was involved, the one before this, and that's part of it is, you know, they take our population and kind of run through to see what admin fees, costs, prescription fees under their plan administration would be.
So we've compared the Cigna network to like the Blue Cross network, a United network, to see which one would be the best for us.
Again, since I wasn't on there, I can't say that we looked at those specific companies, but I do know that we had at least 2 others that were in that mix when Cigna was reselected.
It's more of a plan design. If we ask questions, then we can plan design. Otherwise, we take whatever is a common plan design. An average administrator charge somewhere between $47 and $52 to process employee per month. So they just run clean, coordinate care and pay, collect deductible and pay and coordinate secondary and all that stuff. So that's why I was asking to see, can we nail the network that we can see? Because you're not going to save a lot on primary care because you really want to provide really good care for the patient. But post-acute care and the specialty are the one that we can hold down and see where's the best lower the cost for better service. So that was the reason why I was say, in the long run, do we plan to merge that with our population medical home group to see if we can enhance and nail the network for them versus going outside.
But Dr. Simmons, I can get you some more information about the other participants in that RFP.
You may find that different networks, obviously the same visit, Cigna may pay, say, $100 for the visit. Blue Cross may pay $90 based on their contract. United may pay $110 or something like that. If we analyze that into what we're paying in our claims, we just want to be sure that we pick the best thing for us since we're self-funded or self-insured.
Okay, thank you for that comment. The next section is talking about our pension plan. Just based on the normal growth of participants as well as the increase of expenses of existing participants, it would cost us about $3.2 million more next year. We are going to look at the amount employees actually contribute. Currently, we ask employees to put in 1% of their salary to offset this pension expense. That represents about 10 to 12% of the total expense of the plan. And we are going to be raising that to 2% of their annual salary next year. Other benefits, we have a lot of education. IT goes through some pretty extensive training every 3 years that's required to keep their certifications, as well as continued leadership development. And then we have some increased taxes. So on the FTEs per adjusted patient day, again, this gives us a good idea of, based on volumes, how have we been staffing. So for budget 18, our target was 5.8 FTEs per APD. So far this year, we're projecting about a 5.64 number. And once we put in fully staffed, we're up to 5.72 for budget. So the biggest component of the difference between the 5.64 and the 5.72 is that fully staffed assumption. Even though we budgeted for about 135 vacancies that kind of churn throughout the year, we also have added probably around 56 new FTEs that are related to expanded service or new areas. We are increasing correctional health FTEs by 10.8. We are increasing the additional 9 beds for E3 require about 21 FTEs. The additional admission holding that we're planning to do is about 17 FTEs. Both of those last two will help offload the ER weights. And then on a much smaller scale, we added a third MRI downtown, which is 4 FTEs. And then the medical home radiology out at Northeast is new. And that service increased our FTE count by 3. So, but again, I think the largest impact of that is just the way that they're budgeted. So when you do the division, we have kept our employee benefit expense right at 25%. The blue bar is salary expense, and then the gray line is actually the percent our benefits cost us of total salary dollars. The next large expense, and this really kind of has to do with staffing as well and how we pay our physicians, is in the professional fee arena. So physician fees are budgeted this year at $136 million. The largest part of that represents the claims expense for our self-pay and connection patients back to our community physicians. And that's paid on a per claim basis. We did not increase that significantly, but that's about $65 million of that total. Also in there is medical directorships. Coverage is the other largest component, and our expense for GME. So when you look at what increased and from year to year, what comprises that $5.6 million increase, the largest is really, it's $2.3 million, but it's just a shift. We used to employ, or we currently employ, our dentist and hygienist over at JPS Hospital. We are transitioning them to become acclaim employees, and so by doing so, we have to fund that expense over on acclaim. They do operate at a loss, so that is 2.3 of the 5.6. Also, if you recall, we are continuing to build our surgical program. Again, these guys are employed over on the acclaim side. They converted over mid-December this year, so we're looking at another 2.5 months of expense for this surgical group, as well as full year impacts of all those that have onboarded. You can read through the other services, but we're increasing urology, hospitalist, correctional medicine, and the emergency department coverage slightly. So all of that combined are slightly expanded or new service. The IGT expense is our intergovernmental transfers, again associated with the URIP program. That increased by $5 million. If you recall, you also saw an increase in the patient revenue side, where we get increased payments through our Medicaid HMOs. So that is offset mainly in revenue. And then our professional fees remain pretty much the same, and those represents legal, audit, and consulting fee.
Quick question.
Yes.
Shannon, when we convert, like for instance, the surgical group and all that stuff, are they housing inside or just a contract coming over to? Say again. When we convert the surgeon to acclaim.
So the surgeons are actually employees of acclaim. Mm-hmm. So they came in, we did contract with a third party, and when we moved to the employment model, again in mid-December, all of them are employed.
So all the office and everything else, private office come to us also as well, or just their payroll only?
It's the whole physician, right? Mm-hmm. We do have a couple of contractors, but again, going through a claim. I'm not sure that I understand your question there.
I think the what I'm trying to get to is, are they all 100% working for us, or they still have their private practice? And what do we do with the other?
So what's happening is when we look at a claim, they're going to show up as an employed FTE. And we recognize all of their revenue, whether it's generated from a commercial source or whether we're paying them to see our staff. So once they become employed, we're showing on a claim 100% of their business.
So we're more like an MSO for them.
And there are some examples of contract employees, but I think they're pretty much working full-time, even though they're not formally employed at this point in time. Okay? Okay, so purchase service. There's a lot of items that go into purchase service, and it's increasing by about 11% or $10 million. The largest increase in this bucket is actually license for users from an IT standpoint. So we have to update our Microsoft. Epic is where all of our medical records live. All of the security applications is $3.2 million of increase.
Just a quick question. Is that going to be convert everybody over to that new Microsoft 360, or we still have partial lagger that we still need some?
I would have to get you that information. Yeah.
Do you know the name?
So we can. I'm not sure.
What was the question?
I think we still in the shifting from.
I know that the virtual desktops are a big item in our capital, so we're continuing down that road. Okay.
Yeah, so to answer that question, we have a little bit in Microsoft 360, but when we evaluated the entire staff, because we're not a per user license, we're a per device license. If we would go to a per user license, which is what Microsoft 360 forces you to do.
My question is, how far are we? Are we 2/3 after this one? Or?
No, we're along the pathway of that. We are about 5% down that pathway. Because if we would go to full Microsoft 360, our Office 360, we'd actually increase by about $4 million a year our Microsoft licensing. And so that's why we pulled that back and went to a device licensing.
Slowly.
You got it.
Okay.
You got it.
Thanks.
Thanks, David.
Thank you, David.
Some of the other larger increases are a lot of the radiology and the invasive lab equipment is coming out of the initial warranty period. So we are purchasing extended warranties for that. And as I had spoke before, the mobile mammography, we are going to outsource, even though we own the actual equipment. The actual screenings will be performed in a partnership with UT Southwestern in Moncrief. So that is the expense side of that. It does produce revenue on the other, as I'd shown on the revenue slide. The rest of the items you can kind of read down through there. They're smaller increases, and they're really related to, a lot of it's related to IT or patient care equipment. And again, the IT is related back to our medical records and still patient care. Medical supplies and drugs continue to be one of our higher inflation impacts each year. Medical supplies always end up around 3%. But our pharmaceuticals historically have somewhere between an 8 and a 12% increase. So looking at what we're using today, we've estimated about a 9.6% inflationary factor for pharmaceuticals. 340B, again, we saw some revenue with that. This is the actual drug cost associated with that program, and a small increase in the PAP drugs. So for other expenses, this is a lot of this is where we pay our public health and MHMR services that are received at the county jail. Those are increasing by 4% and 14% respectively. We also have some new equipment for urology providers, as well as drug distribution with the Pyxis machines across the house. And from a computer replacement standpoint, we try to do a 5-year rotation on our PCs and laptops. So that is scheduled to increase about $640,000. You can see the admin costs with the 340B, and the rest of them are very small increases relative to the total.
Sharon, was jail primarily capital equipment, or what was the reason for a 14% increase?
From the MHMR side of the jail, that increase is related to an additional 3 caseworkers that they were requesting, along with increased employee benefits expense.
Okay.
We did have, we also provide the medical services at the jail, and that increase, that's where the 10.8 FTEs were increasing.
And what we've seen, Mr. Petty, is due to a magistrate ruling, it seems that the county is taking on more inmates that were historically in city jails. So they're now at the county jail, and our correctional needs and our correctional health program increases because of the amount of population that is coming through that correctional health facility. So it's a challenge. And one of the things that we would like to work with the county is to have an understanding, a memorandum of understanding, so that they knew what we provided and what we didn't provide. I think that's a fair way to deal with taxpayers, to say, here are the services JPS is going to provide. Should that change, y'all need to look at the budgetary implications of that rather than just deal with it. And we have the same situations in MHMR with an increased amount in trying to figure out how we deal with that.
Does their increase in their caseworkers relieve any of our burden?
No.
It's our burden. I think is a fair way to put it. I'm not trying to be mean. It's just it's what we do.
So the MHMR has also seen an increase in services they're providing for behavioral health. So to give you an idea of the increase in volume for fiscal year 2017, there was approximately a 3,100 per day average daily inmate census. And in fiscal year 2018, our
3,100, say that again.
3,100 inmates a day.
Okay.
And in fiscal year 2018, it's averaging 4,200 inmates a day. But more importantly, now that there's the central intake option requirement, we're seeing an additional 1,800 prisoners per month that have to have a full RN nursing assessment, intake, and everything. And so that's an additional volume for MHMR as well, because they have to have a mental health screening also. And so the increase has been significant on JPS as well as MHMR.
And those are going to be costs that are going to come back to us. They come up every year with more money. Well, we're trying to make cuts.
We'll get into all that discussion.
It's okay. Okay. And from a depreciation standpoint, if you remember, the most unusual item on depreciation is about there's a large portion of what was capitalized for the pavilion when it opened 10 years ago that is finally rolling off of depreciation. So that's about a $5 million savings each year now that it's fully depreciated. So you notice our depreciation looks constant, but effectively it's increasing $5 million. The last item impacting the medical center is just the non-operating revenue. So now we're kind of dropping below operations and looking at what do we earn on, you know, our approximate $675 million. We are restricted by the Public Funds Investment Act. I always try to remind you of that when we're looking at a 40% increase in investment income. We're really just projecting it to go from the current 1.8% earning to about 2.4% earning based on the, I will take it any day. But, you know, I think that context is really important. We are very restricted on what we can invest in. So that kind of brings us back home to the income statement. Again, this comparison is just for the hospital. I'm going to cover a claim here in a minute, but earlier, I guess late last month, we had talked about the 25 million or 25,000 where we kind of expected to end the year. I do want to point out that the impact of the change for fiscal year 18 of that federal funding is $16.3 million. So that's going to put us at a operating loss, pretty significant operating loss. Now, if you added all the numbers that I just went over, before we decrease our federal funding expectation by the $13.3 million, we would have had about a 2% margin on the medical center or $20 million. We do have to take that out because we do know that that is likely going to happen. So that's where we're getting our 7% margin, or about $6.8 million. Bottom line, after our non-operating revenue, we're at about $23 million.
If it weren't for that pesky federal supplement, we would be doing really well. It's just challenging.
So, you know, it is important to understand that we made up for a portion of that 13, but we're not able to make it up completely in next fiscal year.
Hey Sharon, when we transfer dollars to our rainy day fund, if you will, does that change our investment requirements relative to liquidity of those dollars, or are they basically treated like any other?
They are treated like any others, okay. And we leave those dollars at Hilltop, okay, along with our other investments. Okay. If you looked at your Hilltop report, there's actually JPS Future Fund designation, okay, but it's just a proportion, okay, of that total fund.
There's no additional liquidity requirements, though. Okay.
No. And because it's a board designated, not a donor restricted fund, it really, like when S&P or Moody's or an external source looks at us, it's included in our days cash.
Okay, thanks.
So that is the medical center. Capital budget for this year, as Trent, you know, he is the master of segue, right? So he does not mean to do that for me. The JPS Future Fund, right now we have about $117 million in that fund. We are proposing this year that we add another $10 million. We have been able to set aside about 10 million from our 18 capital budget. There are some savings that we had. There are some projects that we did not move forward with. And so I would propose that 10 million additional dollars be set aside for the future construction projects. And then as you look at, there's another 7 million in 19 capital that we set aside, as you can see here. We typically try to fund depreciation, 39.7 million. Our master facility projects, we're gonna back out about 7 million there. So when the operations team came together, we decided how to use the remaining 32.7 million for maintenance capital. The majority of that went to patient care equipment at 18.8 million. IT infrastructure cost us another 8 million. Again, that is what supports all the connectivity of that equipment as well as our EMR. We do have some small facilities and renovations that we budgeted, and then we always set aside about $500,000 for unknown. So if you want to take a look at what makes up some of that, there's a page in here that you can look through for the construction. Again, the total is just over 5 million. We also have maintenance equipment. Again, the two large items that kind of fell out are the linear accelerator for 3.8 million, as well as a replacement of the telemetry monitors. Monitors, as you heard earlier in this meeting, can be very expensive. So that's a $3 million total replacement. So unless there's any questions about the operations for the medical center or the capital, I'll go ahead and move on to a claim. Okay.
I have a quick question, Sharon. I know you probably covered this. Forgive me if I missed it, but on the payer mix slide, which was number 15, how was that calculated? Is that net patient revenue?
No, it's based on gross, so it's based on charge.
Okay.
So that way, a self-pay patient gets just as heavy a weighting as a commercially insured patient. If it were based on collections, you would just have like a sliver for that 39%.
Correct. I'm assuming we could get that data, though, if we wanted to review it.
Absolutely.
To see what our net collections are.
So we typically collect just less than 1% from our self-pay population.
And also, I didn't see any occupational health or employee injury in this. Is that somewhere else in the budget?
Yes, that would be part of benefits. We have workers' comp costs that are paid. I think they're paid on actual claims, but we also have an employee health clinic on site, and we can go there for either wellness or work-related injury.
Are we self-insured for work-related injuries?
I don't know the answer to that. I'd have to get back with you.
Okay. As a non-subscriber. Okay. Thank you.
All right. Okay. If you need to get up and stretch, please feel free to do so. You know, I'm hoping this isn't going to take too long. So, you know.
We're going to keep the blinds down, though, so you don't know whether it's dark or light outside. So, thank you, Mr. Chairman. You want to take a 2-minute vote? You want to take a break now?
We could. We can have a 5-minute break. Okay.
Yeah.
That's great.
Good idea.
I have. I'm going to sound like you do after a while.
recess. Sharon, thank you for all the time you're giving. We will get back into the budget presentation, and to Ms. Clark, we'll turn it back to you at this time for the continue the presentation. Thank you.
Just for the audience's sake and you board members, there's a chance that there's only 4 to 5 hours left in this presentation. Just setting expectations.
Charlie ordered dinner, I think, at 7.
We did.
So,
We did.
all right. So for a claim, we have, and I'm going to spend some time on this slide because a claim is very repetitive. When we hire physicians or start new services, there's income, there's expenses, so it's almost like the revenue and the expense slides are exactly the same. As a reminder, we have onboarded 41 providers so far this year, and there's a few more planned. And so you'll see the encounter growth is about 6% higher. We are growing urology, as I mentioned, on the medical center, physician payment slide, as well as maternal fetal medicine. There's a bit of decrease in academic funding over the next 2 years, so that has been budgeted as well. We are transitioning about 14 dental providers from JPS to a claim, and we are also transitioning the correctional health providers from an external group into a claim as employed staff. We, just like we do on the medical center, there is always a focus on revenue cycle improvements, and the district transition that I spent quite a bit of time on at Finance Committee, that $4.4 million has been removed both from 18 and 19, but included on the medical center slides prior. So if you have a number in your mind that you remember seeing from as a total loss, remember that we have completely removed $4.5 million from their earnings and put it back over onto the hospital. So as I mentioned, we have budgeted for 458 providers. The increase of 24 comes from the dental and the correctional health transition. So these are providers that we've had. They have just not been employed by a claim. And there are some administrative positions, as you can see in the changes column, but that brings our total employees in a claim to about 617. With that increase, we have a 5.7% growth in encounters. And when you put all of that together, our net patient service revenue increased by about 3%. Again, a lot of growth in surgery as you account for them to be a full year in this corporation. One thing I do want to talk about is that last item. You're going to see a decline as JPS Connection pays the acclaimed providers. There is a contract in place where we withhold, it's a 3-year escalation, so we are withholding a percentage, 5, 10, 15% of their total payment, so that at the end of the year, if they meet their agreed upon quality metrics, that they can achieve that pool back. So you see a $2 million decline here in the flat base payment that we're paying, and on the next slide, you're gonna see a pickup in other revenue as that quality bonus is paid. So it's really just a reclassification. For budget purposes, we have assumed about a 70% achievement rate that you'll see on the next slide. So for other operating revenue, again, these are all other collections other than what is generated from a commercial payer or Medicare or Medicaid. The largest portion of that increase is from JPS. Again, we have the dental providers, and we have the increase in the surgery and trauma services. The full year impact for urology and correctional health are all included in that 4.8 million. We also just talked about the connection quality incentive. That's 1.5 million for a 70% achievement. If they achieve a higher level, then that's the amount that will get paid to them. The plan reduction in academic funding over 2 years, and we did lose our meaningful use. That program's pretty much expired in 18, so we had gotten about $500,000 from that. Salaries and wages, we've talked about the onboarding of the providers, the full year impact, the dental and the correctional health. You have benefits associated with that growth, and we saw in the FTE slide some of the support functions that are required as we get fully up to speed in a claim. Under the physician payments, you can see that that is actually going down because a lot of the contracted people that we were out, and some of this represents planned employment, but our salaries went up, and providers that transitioned from a contract status is the 4.3 million savings. And then we have a bit of an increase with maternal fetal medicine as a contracted group. Other operating expenses, purchase service is one of the larger increases. A claim does pay back to the medical center items that are used. The largest of that is their Epic cost. We pass those through, and also kind of a per charge rate on their PCs. A big expense here is also the transition of the CMO and the CMIO are 50% on the medical center as administrative, and 50% still patient care. So that 50% payment back to the medical center as they see patients is included here. And you can read through some of the other smaller changes. I think I've mentioned most of those where they relate to rev cycle. So when you look at the total acclaim statement, and over the last year, we've talked about a claim quite a bit, either at the full board, I've made presentations, or during the finance committee. Because we are increasing providers, I always find it helpful to go back and calculate the loss per provider. And that's been provided to you at the bottom of the screen. Again, we've got about 458. That is about a $51,000 loss for those folks. The MGMA median loss per provider is about 158 from a national average. Are there any questions on a claim? I went through that really quickly. They did have one capital item that has been included in the larger capital budget that I just went through, but that's just for the orthopedic area.
Sharon, why do you think that difference is so huge on the median loss provider?
You know, some of it could be regional, but the national is what we have always shown to you over the last 3 years, so I didn't want to change medians on you. I have not been able to dig into that to find out what's driving that cost difference. 2 years ago, that cost was $70,000. So It's not the fact that we've changed what we're doing. It's that for some reason that median has doubled in the last 3 years, but we've remained relatively the same.
The median has doubled in the last.
It has. 2 years ago, that the 158 per provider was in the low 70s.
You got to believe it's being calculated differently. Yes. They're loading the cost somehow.
Yes.
In a different way than they used to.
And I think the number of participants that respond are right at 100, somewhere close to that. So it's probably a very wide range within that median. Are there any other questions before I move on to the foundation? All right, so the foundation is really a support function. And just as a reminder, we have 3 things that go through the foundation. It's all the fundraising and the donor activities. We have donor restricted gifts that are captured there until they are spent. And then we also run our Connection Supplemental program through the foundation. And that is the program that after they meet certain income requirements, we can actually help an insured patient with their high deductibles and copays. So I've tried to break this up into the 3 sections that I just talked about for the total budget. And the one thing, the main reason we show you this is because the medical center funds the foundation activities. And again, the foundation is not just a fundraising arm here at JPS. They also manage a large portion of our grant activity and grant writing, as well as grant reporting after we have that. And they're the ones that also do a lot of the public relations and education about who JPS is and how we fit into our community. All of the tours, most of the tours are done by the foundation staff that we're all familiar with.
And the annual meeting is phenomenal in terms of community relationships.
The breakfast in November, agreed.
Mm-hmm.
So there are not any major changes in the foundation's expenses. We did budget again for them to be fully staffed. That's the large increase in the salary number. And that is really my prepared comments. Again, there weren't any major changes.
Dr. Heyer texted me and said he's a little bit late and he wanted to know if you could start again.
You know, I think somebody might have been recording me, so yeah, that's not a problem at all. So when you put, again, this is the same slide that you saw at the beginning of my presentation with the medical center, with a claim, and with the foundation. You know, the bottom line is effectively a break even. The medical center was able to budget a 0.7, including the $13.3 million reduction. So this is our operating margin is a loss of $16 million, but we were able to budget a net income of $271.
It's all yours, Tom.
Sharon, again, thank you for that presentation. And it's easy to say it was a long presentation. As Steve started this, there was a lot of hours it took it to there. So on behalf of the finance, entire committees and your staff, we appreciate everything. Obviously, it's easy for me to say, are there any questions? We've had a lot of questions as we've gone along. I think by getting it out on the portal, giving everyone access to it, I know many of the board members, I appreciate their input. They reached out to you. I know you answered a lot of those questions. They know, as with anything, as we go through the year, if there's some additional questions, if they can address it during the next meetings or through the finance committee, we will certainly look into it and dwell with it and get back. So that being said, are there any other discussions of the budget as presented? before I would entertain a motion, they have to be taken in as individual motions. I would entertain a motion for the fiscal year 2019 Tarrant County Hospital District operational budget.
Mr. Chairman, first I want to congratulate Sharon and her team on the hard work. We set a high bar for you, and you met the challenge, and so we really appreciate it a lot. And I do appreciate the opportunity that this entire board had to review it and ask questions, and I do think we all walked in with a good understanding of what we were going to hear today, but it was still great to hear you go through it anyway. So having said that, I do think it's a very responsible budget. I do think it demonstrates good stewardship of this institution and the public's dollar and our mission. And so I would move that we adopt the fiscal year 2019 Tarrant County Hospital District operational budget.
I have a motion.
Second.
I got 3 seconds here, but anyway, I'm DT. I think DT got there first. Mr. DT Nguyen on the second. All those in favor say aye.
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 Thank y'all very much. The next item falling under that agenda item is the fiscal 2019 Tarrant County Hospital capital budget that was as presented.
Mr. Chairman, I'd like to move approval of the fiscal year 2019 Tarrant County Hospital capital budget as presented by Ms. Clark.
Second by Mr. Petty. All those in favor say aye.
Aye.
Opposed, no. Thank you very much. It passes. Item number C, the fiscal year 2019 acclaim budget as presented.
Mr. Chairman, I would like to move approval of the fiscal year 2019 acclaim budget as presented by Ms. Clark.
I have a motion. Mrs. DeBose, and I have a second by Mrs. DeBose. All those in favor say aye.
Aye.
Opposed, no. Thank you so very much. And then the last item there is the fiscal year 2019 ad valorem tax rate notice as it was presented.
Mr. Chairman, just a minute, that specific motion has got to have the specific tax rate.
I got it.
You got it? Okay, I just want to be sure we're on board. Okay, all right. Okay.
Look over your shoulder.
We have not done that in the past, so I just want to be sure.
For Aggie, I'm laughing you again.
Yeah, excuse me, we did have a UT person correct you, Aggie, over here. I just want to make sure we got that right. Thank you.
We're used to it.
Yeah, it makes me know forward. I think we have a motion coming. I will recognize Mr. Montgomery as
Thank you,
finance chair
Mr. Chairman.
again.
I would I recommend approval of the recommendation to Commissioners Court that that they adopt fiscal year 2019 ad valorem tax rate notice of 0.224429, which is the same as the current rate, which represents a 0% increase. Is that sufficient, Council?
Did you say 0.0 or did you say 0.2?
I said 0.22.
0.02, isn't it? Tax rate?
Tax rate.
0.2244.
It should be 0.2.
0.2244.
44.
Okay, we won't go on Neil's, okay?
Value.
Well, if we go on Neil's, we gotta go redo the budget.
Start it over.
Yeah.
Oh, God.
It's per $100, but that's how this tax rates are stated, is per $100
Yes.
of value.
And since we've been saying as presented, that was the number as presented in the budget. I think Mr. Bose just read it as it was presented. We need to have some clarification. All right. Back to the motions. I do have a motion for the fiscal year. I have a second by Mrs. DeBose. All those in favor say aye.
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 Opposed, no. Thank y'all very much. That takes care again. I know, Sharon, thank you very much for your presentation. I will have the minutes so reflect that item number 14 on the budget, all four passed unanimously by the board. Thank you for everybody's attention. And yes, hey, great job. I know we just took a small break. That does bring us down to really the closed session portion of our meeting. I'm told that there is not much that we obviously have.
Mr.
Oh, I'm
Chairman,
sorry.
if we are in closed long for any reason, it will only be up to Dr. Schrader. So I want the audience to know and everybody else to know that the only reason there would be any delay would be because Dr. Schrader.
Yeah. But before I announce we're going to close, I'm sorry. I missed it.
Mr. Chairman, just 2 items before we go into close.
Okay.
First item, I would just encourage my fellow board members that with the outstanding job that Sharon did, that if some other question comes up, that we would come back here and not go to our commissioners. So that we don't get the commissioners court and then we get questions that we may have raised with our commissioner and didn't present it here at the board.
Gotcha.
I think out of due respect.
That's a good point.
And what we will do is, as we have historically done, we have set up meeting times to brief all the commissioners, but it is our process by which board members debate this budget first. And now Sharon and I will go to each commissioner and meet with the commissioner and go over this budget in any length of detail they wish. So we will be doing that with them as well.
The other item is, I know earlier we passed the resolution in reference to the bond program, and I leaned over and talked to our legal counsel and asked if there was any way he could do some type of workshop, training, instructions, directions to we board members on, I don't have the right term, but on outside influence to us going into this bond program, especially after I saw what took place in Dallas today. Right.
Bill, you want to respond to that? Because
Reverend, interesting you asked that question. It is a serious issue because there are criminal sanctions, there are statutes that govern what this governing body does, what Robert and his staff do in terms of the bond election, but those will not really go into effect until the bond election bond's called by the County Commissioners Court. Once it's called, I provided yesterday Mr. Powell and Mr. Early a draft legal opinion for me in terms of what's advocacy versus what's education. And if you cross that line, then you got potential criminal penalties, as has been going on in Dallas on some issues, as well as some other public entities around the state. And there's AG opinions left and right about it. So I have a draft. I wanted Robert and Charlie to see it. I want to be sure it flows and reads and says what it needs to say related to being sure to clearly communicate to you and to Robert's staff. So once you get a copy of that and they sign off on it, we get a copy to everybody. Then we can talk about, you certainly can look at that, call me, we'll talk about it, or if we need to have a work session on it, maybe at the Finance Committee meeting or something like that.
Yeah, so. Ralph, I think, and you may want to cover this, Robert, we don't want to anticipate or know exactly what the Commissioners Court, as we know today, the resolution strongly supports, and we're very positive as to their actions they will be taking at one of their future meetings. So we didn't want to be presumptuous, but I think in anticipation of that, Neil was asked to look into it, and I think we'll probably come back in either one of our meetings, whether it be in governance or be in some other meeting, have something to make sure we don't do something outside what even though we're in support of it, there's certain things we're bound by law we can't do. So Neil's
my advice will be that if
Robert, you may have some additional comments.
That's the moment where you
yes.
really need to get the information out to you as quickly as possible, because it's pretty easy to cross that line.
Two things, Pastor, that will help you. One is we still have our current protocol in place for staff members, executive team members, and you as board members not communicating with those who might have any business before JPS regarding any potential bond package, and that protocol still stays in place. And Dr. Simmons will give you that protocol so you feel comfortable with that. And I've had the luxury of talking to some vendors that have been quite kind and understood that process and understood that protocol when I said the level of ethics that we have here at JPS is going to be of this magnitude, and here's how we're going to do things. So that protocol still stays in place. In addition to what Mr. Adams is doing from the legal side, our communications team, JR, has already begun to put into place a timeline and a time frame. Should the county commissioners call a bond package, then there will be an actual process by which we will communicate with all the employees what they can and what they can't say. That will have the legal elements to it, and also we'll begin to discuss that for the employees. We'll also be able to discuss a little bit that at the town hall meetings Friday and Saturday and Monday as well. Again, not foreshadowing what the court could or could not do, but just preparing, because there's been media attention to this subject matter. We would inform the employees as well.
And I think you're right up to speed, Ralph. I actually say you acknowledge what various things happened to the east of us today. I'll only tell each one of the board members you need to memorize Scott Rule's cell number and his phone number, because I don't know what else he does at JPS. I know it's a lot, but I know I give out his number a lot, but I don't discuss this. Call Scott Rule. Well, he's Scott Rule? Call him at this number. So, Scott, I'm going to tell you, thank you for what you have handled, but get ready. I do believe Ralph is right. We probably are going to get those contacts. It's just great to say, call Scott Rule. So, anyway, is there anything else, Ralph? Acknowledge Ralph. Anyone else before we take we won't take but just a second to clear the room for closed session. We should be right back. So, at 3:45, we'll take about a 5-minute for a quick deal. at 4:55. We will reconvene in open session. Oh, 3, excuse me. Yes, it is. I thought that budget lasted. Sorry, Sharon. I thought the budget took an extra. Yes. Well, who made the comment about the blinds being? They really are closed, so it could be dark. But anyway, thank y'all very much. We will reconvene at 3:55 in open session. I'll ask if there's any other business or anything, and Chet, I'll turn it to you.
I'd like to recommend approval of the medical staff recommendations.
I have a motion. I have a second by Dr. Simmons. All those in favor say aye. Any opposed? Also, as I would say again, there being no additional business to come from this board, thank you for your attendance today, and we stand adjourned. Thank you very much.
Thank you all.
Thank you all.